Welcome to today's speaker series. Thank you all for joining. My name is Rosa Staltieri, and I'm the Knowledge Translation Manager with CanCOVID and also the speaker series moderator. So what has been the role of Canada's supply chain capacity in responding to the COVID-19 pandemic? So it's a great pleasure to welcome Dr. Snowdon, who will be presenting emerging findings from 7 Canadian provinces, and that will shed light on this very same question. Dr. Snowdon is a professor of strategy and entrepreneurship at the University of Windsor and scientific director and CEO of Scan Health, located at the University of Windsor's Odette School of Business. And Dr. Snowdon will be presenting on behalf of her colleagues, Dr. Michael Saunders and also Alexandria Wright, who is a PhD student at the University of Toronto. So before we get started, there's just a few items I note before every presentation. We just ask that you ensure that your microphones are on mute during the presentation, and that for the 10-minute question and answer period, we welcome you to ask your question live by raising your hand or typing your question in the chat box below. So I'll hand that over to Dr. Snowdon.
Thank you so much, Rosa. It is an absolute pleasure to be with all of you this afternoon, and thank you for taking time out of your schedules. I know despite this pandemic, you're all incredibly busy. Michael Saunders and Alex Wright, who have written the paper with me, are online as well, so we'll look forward to our discussion and dialogue, and I'll walk through what are some of these findings and look forward to your thoughts and comments, as this is work emerging from a CIHR operating grant that was funded just a mere few months ago, although it seems much longer. So what was the objective of this research? It was to do a number of things. One is to do a comparative analysis of provincial health system supply chain infrastructure and processes that support health systems to deliver care during such an unprecedented pandemic. It also was designed to look at the digital maturity of supply chain infrastructure. I probably won't talk a lot about that today, but I will touch on what we're seeing so far. We're also examining policy frameworks. My colleague, Dr. P.G. Forrest at the Policy Institute at University of Calgary is heading that particular part of the research, and looking at the effectiveness of federal, provincial, territorial coordination of supply chain infrastructure. So essentially, this research is doing a deep dive case study with the following provinces listed below: British Columbia, Alberta, Manitoba, Ontario, Quebec, Nova Scotia, Newfoundland, and Labrador. The only reason it wasn't 10 provinces, if you recall, this call for proposal, I think was only 11 days. And I was able to connect to 7 provinces and not 10, and without the territories. So it really was just a very rapid research strategy. The methods are mixed methods, of course, long and deep qualitative interviews. I think we're up well over 120 at this point, and the list of the various perspectives and insights are listed on this slide. We're really looking also at COVID-19 outcomes. CIHI has provided at the provincial level so that we can map what was the capacity of supply chain to respond to the multiple and ongoing phases of this pandemic, and what were some of the COVID-19 outcomes using the CIHI framework for COVID-19 established very, very early on in this research. The conceptual framework, really briefly to give you a sense of it, the interviews at the bottom and some data on supply chain processes and supply chain infrastructure, which are very much embedded in the literature as being very critical for health systems to be able to source those products they need in order to deliver care, distribute them, get them exactly to the teams and locations and organizations where those products are needed quickly enough to meet the demands, of course, for what most health systems experienced in the various phases of this pandemic. The capacity to deliver care, of course, is fundamental to having the products in hand, and we are certainly experiencing that as we speak today. Just think about vaccines. We have all this vaccination infrastructure set up, teams ready to go, except we can't source enough of those products, vaccine doses, quickly enough. So it gives you a sense of, for the first time in many years of research in this space, just the critical strategic role that supply chain infrastructure plays in health systems capacity to deliver care. In some ways, I've had conversations with some leaders that suggest we don't think of it this way, but the supply chain of our workforce is looming large in this pandemic, and we'll talk a little bit about that as we go. As you see at the top, the health system outcomes we're looking at are health status, the volumes of COVID-19 case outcomes, whether there were recoveries, mortality rates, of course, responsiveness to care, the value and costs, which have been remarkably tough to access, and of course, equity, which many of you have probably seen as well. So what we've really identified in this phase, and we're about 2/3 of the way through this 1-year study, are the features of fragility, we are calling it. And those are the key features of a supply chain that are ever so tenuous in making sure or supporting health systems to do all the care delivery that they are often required or demanded of them in such a pandemic. And I'm going to talk about each one of these and the impact of each one. So decentralized leadership strategy, we'll spend a moment on that very briefly. What does a just-in-time supply look like, and why didn't it work? Why did it create challenges? Sourcing of products from single geographies, manual supply chain processes, lack of product data, why that matters, and a reactive approach to supply chain management that we're seeing across some of these provinces. So let's start with the first one, decentralized leadership. 2 provinces in particular were quite distinct from others being BC, Alberta, Manitoba to a large degree, Nova Scotia and Newfoundland. And that was the issue of having a decentralized leadership strategy rather than the very centralized one team is in charge for the whole pandemic response for the whole province, which we saw heavily, certainly in British Columbia, Alberta, and very much so in Newfoundland, Nova Scotia as well. But Ontario and Quebec were quite different. There was no, and still isn't, a centralized agency or model managing supply chain in either of these 2 provinces. When they began to experience that first wave, what the strategy was to hospitals first, prioritization, and of course that was heavily influenced by all of the many social media influences all of us saw as this pandemic unfolded in Wuhan, then Italy, which was profoundly overwhelmed, UK, of course, New York City. So there was a very, very direct focus on hospitals, make sure they have the capacity, the beds, the equipment, the products they need. Interestingly, though, that left community health agencies, long-term care, all the other health organizations, primary care as well, to figure out how to and where to source and access PPE shortages. There was a number of weeks where they were completely independently looking for PPE in these 2 provinces, compared to the other provinces with very centralized leadership, where all PPE was identified in the province and distributed to all clinical teams, whether you were a hospital, a long-term care setting, or a home care setting. So there was a very distinct challenge when you have a decentralized leadership. Many of the organizations had to manage their supply chain infrastructure and sourcing and getting their hands on PPE at times of tremendous critical shortages with very, very significant impacts, long-term care being just one of them. And I'll speak to that in just a few minutes. A second fragility feature is the inability to manage a surge in demand. And if there's probably one, although there are many lessons learned, I think, so far in this pandemic, this is probably one of the most substantive changes that we are expecting and are already seeing in how supply chain management is organized in Canada. Really, pandemic stockpiles were either completely inadequate, meaning there was 30 days of a pandemic PPE available, but 30 days of regular use, and at the rates of use that we were seeing in this pandemic, that was literally gone in 3 days, leaving organizations, particularly again, community organizations, long-term care, with nothing. Some had absolutely no stockpiles. So, and the demands for product use, just one province shared with us, they on a typical day for the entire province, used 33,000 masks a day. In that first wave of the pandemic, it was 760,000 masks per day. So you can imagine the volume of products and the rapid speed of utilization of these products, and just how unprepared our supply chain infrastructure was to meet that demand. Group purchasing organizations is something many health systems use. They identify where your sources of product supply are and how quickly they could be replenished. They were completely unable to go back to their suppliers within those existing contracts and increase the supplies in those contracts. The only thing they could do, and virtually every one of them did for every province, is say, look, we agreed to provide X number of masks per month. That's what we're providing, and nothing more is available. So they were not, they had no ability to manage the demand and surge. And what's happening as we speak, literally as we speak, is health systems are now opening up, looking for other supply sources. And they're no longer just purchasing and contracting, to provide a certain number of masks per day, like 33,000 for the province. They are now purchasing manufacturing capacity, meaning in those procurement contracts, they are now agreeing with manufacturers, in the event of a surge, you will promise us to give us 20% or X% of your capacity to produce product, so that they never again find themselves literally without anything. One provincial leader said to me, Anne, at the beginning of this pandemic, I could put the entire province's PPE in the trunk of my car. That's how limited we were in this product supply. So that was a real challenge. One of the reasons for that challenge, and you'll get a sense as I keep going here that there's deep interrelationships between these factors, is for years we have prioritized in healthcare, and this is not unique to Canada, by the way, it's everybody, lowest possible cost for the best possible quality. What that means is 90% of health systems in North America wide were procuring all of their supplies from China. Well, of course, China was the first geography to be quarantined in this pandemic. So that means immediately shutdown of manufacturers. So 90% of the sources and supplies of our products for Canadian health systems gone in what seemed like overnight. What health systems did very rapidly to try to manage these severe shortages is look to the domestic manufacturing capacity in their local region. So Ontario looked at their automakers and said, can you manufacture ventilators? Newfoundland looked at some of their clothing manufacturers and said, can you make gowns, and so on. So what's bubbling up now to overcome this single sourcing, and what many leaders are sharing with us, is never again will we put all of our supply sourcing into a single geography, and they are absolutely distributing it globally. As another feature, third one, I think we are, in supply chain infrastructure in Canada, and I suspect Canada's not alone on this, but I think Canada is probably one of the furthest behind, as I've now worked with and studied Australia, New Zealand, US, and some of the countries in Europe. We have almost no infrastructure in most provinces, the exception, of course, being Alberta, and there would be no surprise that Alberta was able to not only acquire and source PPE, but they have such digital maturity that they know exactly where every box of masks, gowns, gloves, hand sanitizer is in the entire province on digitally enabled dashboards that change in real time. So they had complete transparency. Of course, Ontario and Quebec, with a decentralized leadership structure, no centralized agency managing supply chain, absolutely no transparency. So without digital infrastructure to know what product do we have, where is it most needed, how quickly are we utilizing product, you have what I call as flying blind. You are making decisions, hoping for the best based on primarily estimates. What Ontario did was create what they call a virtual inventory about 3, 4, maybe 5 weeks into the first wave. What that meant was create a website or a platform by which organization teams could count daily what their PPE product stock was, call it in or email it into this virtual inventory. And that was the only way they had any idea of where their supply shortages were. But that was primarily for the hospital sector, and the community sector, again, if you recall in that decentralized leadership feature, was not prioritized. So they were doing their best to manage, no digital platform whatsoever to do so. Where digital tools existed, so some tools, there was some digital infrastructure in some provinces where they had regional health authorities. The catch with that is one regional health authority digital infrastructure didn't connect or wasn't interoperable to another regional health authority. So what those provinces had to do is bootstrap it, try to create very quickly on the fly ways for these digital tools to connect so they had some visibility to what their product inventories were. The only province we could find that had some sense of utilization rates, like how quickly are we burning through our inventory of PPE, was Alberta, because they had this digital infrastructure. Very, very few, if any, of the other provinces were able to do that. If you can't track your supply utilization, you don't know how quickly you're using it. Extremely difficult now to go to your procurement team and tell them, I need this many masks this quickly in order to meet demand, because you have no line of sight to what your utilization rates are. So that was a really significant fragility feature. Here's another piece that's linked to data, so you're getting a sense the digital infrastructure is so critical in a robust and resilient supply chain, and that is lack of standardization of data. Let me give you a quick example. In one jurisdiction, they shared with us, we have 56 different kinds of gloves. None of those gloves are actually identified with a common set of data. So you can't know whether that's a latex glove or a non-latex glove unless you read all the product materials, look up that product on their manufacturer website, and hope you get it right. Because Canada has not adopted global standards, GS1 standards. Every other business sector virtually in the world has product identification standards. So a simple scan of a barcode, you know exactly what the product attributes are. We have not done that in healthcare, and that was a limitation. One of the reasons that became so problematic is when N95 masks were profoundly critically short, we were completely unable to look at an alternative supplier that was producing masks, telling us that they had the same functional features as an N95, but because you have no standardized data set to work from, we were never able to make sure that that mask that's not an N95 has all the same functional capacity or capability as an N95 and therefore would be acceptable. What happened in a lot of jurisdictions is we bought masks, clinical teams looked at, completely unable to use them because they just didn't meet the quality standards they needed to. So data standardization is a pretty significant one. The last one that we noted very, very clearly is there's a remarkable difference in a health system that has a very proactive approach to supply chain, meaning they plan for demand surge and challenges of product interruption. Most provinces that we have studied were very reactive. In other words, they were creating supply chain processes as this wave 1 or wave 2 phases were unfolding right before our eyes. So one of the things virtually every province did was create an allocation formula. What does that mean? If I'm a nurse in critical care, that means that I can no longer make the decision as a nurse that I'm going to go in and help this doctor intubate this patient, and therefore I need an N95 mask. An allocation formula meant I was given a certain number of masks and I could not use any more than that certain number, and they might be an N95 or they might not be. That created profound anxiety and uncertainty in our health workforce. And we saw over and over again the fear, the uncertainty. Will I be able to go to work and be safe and not take COVID home to my family or to my loved ones? So those allocation formulas were well intended. They were meant to conserve products that were so short in supply, but generally they created tremendous uncertainty and anxiety in the workforce. There was also no planning for mass testing. We were creating these testing protocols and testing processes as we needed them. And as you well know, mass vaccination was being developed literally while the same teams and public health teams across the country were also trying to manage wave 1 and wave 2. So all to see, we were not prepared as health systems. Our supply chain infrastructure was similarly not prepared. So we did the best we could. We reacted to all of the challenges as we came across those and got as close as we could, but needless to say, we have much to improve on as we move forward. What are the big areas of impact, just as in a nutshell, before we close off and open up for questions? Without a doubt, a profound impact is the workforce. Workforce confidence in the safety of the workplace in many community settings. They had as high as 30 to 40% absenteeism rates. One, out of fear and uncertainty, but secondly, because our workforce, particularly in communities, became ill with COVID very early on, and of course then had very long periods, 2-3 weeks and counting, of being in quarantine. A culture of compliance versus culture of collaboration. So well-intended, allocating, you can only have this much PPE to use for your particular shift. Health workers weren't required to comply, rather than sitting down with teams to say, how do we work best with the very few products we have? So there's a lot of threads starting to now emerge in our case studies around the value of collaborating with our teams rather than simply giving them the sets of rules to follow. And the very dynamic communication in this pandemic was challenging, constant changing that I think you are all aware of, from whether it was the media changing to the directives on public health management. No question, long-term care. Canada has among the worst rates of long-term care outcomes for COVID pandemic than any country in the world. Then we had about, I think the number now is 66% of our deaths for COVID were in the long-term care sector. The next closest in the OECD group of countries is 40%. So this is one where we need a great deal of thought and a great deal of getting our act together, if you will. Forgive that term in long-term care. That is a very significant outcome for Canada that I see in no other country. SARS was a coronavirus as well a number of years ago. There were over 200 recommendations. None of the supply chain from these failures, and learning and embedding them into the DNA of our health systems. And really this pandemic perhaps is a silver lining, is it's the couldn't agree more. Had we done that, I can think of, they were able to identify their greatest at-risk population segments. They wrapped public health measures around that group, and they didn't have any of the outcomes we did. So you're absolutely right. The catch is you have to have a data infrastructure to allow.
Dr. Saunders or Alexandra, right? Around
these particular products. So I think the fix is in the works, but it was a lesson we unfortunately learned a little bit the hard way, I would say.
Okay, great, thank you.
So our next question is from Donald, and the question is, what global organizations, WTO, WHO, and what these lessons be shared with to strengthen and develop standards of practice in both domestic and global capacity that will have us better prepared for the next crisis? And can this work be leveraged in Canada and globally?
And Dawn, you never fail to ask the big, tough questions. So thank you for joining me today. It's wonderful to see your name on the chat. It's a fabulous question. Actually, we and Alex and Michael work alongside me on a NCE, a knowledge mobilization network, which is global. And one of the strategies we took on was to create a supply chain maturity tool, meaning a roadmap, a strategic roadmap that allows health systems to measure how strong is your supply chain, what is it able to achieve, what strategic positioning does it have in your health system or your organization. So that tool is implemented and driven by the HIMSS Global Network. It's already open and made available to 55 countries. This research actually continues to inform that supply chain maturity tool is become now very critical. In organizations in US, Canada, Australia, who had very high scores on this supply chain maturity tool, did not see these fragility outcomes that we saw in Canadian provinces who did not. And by the way, Alberta is one province that does have quite a high supply chain maturity score we've measured. So it really is a testament to a strategic roadmap for health systems globally. Whether it'll get to WHO or not, Dawn, I'm not sure, but I certainly will work on it. I haven't quite had the time to figure out how to get that, but happy to have your help if you have any suggestions.
Perfect. And we have another question from Manis. Manis, please go ahead and ask your question.
Hi, Anne. Pleasure to meet you. I actually wanted to sort of follow up on your comment about digitization and data, right? I think we also need to recognize that the reason why healthcare in Canada, and this is because I'm US-centric, may not have taken on this task because there's not enough supply chain management education among healthcare executives, right? Yeah. And then so in addition to the technology solution, this is where I think healthcare executives may benefit from just more supply chain management education, because a lot of the fragility attributes that I identify, I think, in the private sector, these are already attended to and perhaps will have value to just the healthcare sector in Canada. So anyway, just
no, you're absolutely right. I've been asked many, many times, why is supply chain so far behind in healthcare? And that when you look at organizations like grocery, they can track and trace a head of lettuce right to the farm and the row it was harvested from, largely because business schools who teach supply chain tend not to teach supply chain to physicians, clinicians, nurses, healthcare leaders. They teach primarily within non-health sectors. Now that is just starting to open up, but it has not been, most business schools in Canada do not necessarily teach supply chain in healthcare. So it's a big gap. We have partnered with the Canadian Council of Health Leaders, who based on this, the data, this study and others, are going to develop that curriculum for health system leaders, because you are absolutely right. It's a very big gap, and one we're hoping we'll be able to fill at the end of this research.
Thank you, Anne. I'll follow up with you more one-on-one, because
yes, absolutely. I'd love to.
There's opportunity to collaborate. So
wonderful. That's it'll take all of us. So I'm quite thrilled to have any collaboration out there.
Thank you.
All right, so it is 4:31, just out of time, but I just want to take the opportunity on behalf of the CanCOVID team and network. Thank you so much, Dr. Anne Snowdon, Dr. Michael Saunders, and also Dr. Alexandra Wright for presenting to us today. And just a little update, please join us for next week's presentation, which will be held on the 23rd, so next Tuesday, who we will hear from Dr. Ivy Borgano, and she will present to us on how the pandemic exposes critical gaps in the healthcare workforce and data infrastructure. So thank you all again for joining, and have a great rest of your days.
Good luck. Thank you, everybody, for joining us today.